For everybody with an interest in NASH, or more broadly, fatty liver disease, Surf's Up, Season 3, Episode 46 of Surfing the NASH Tsunami. Our review of the NAFLD Summit starts now.
This week on Surfing the NASH Tsunami.
In meetings like NAShdAQ and this one, you get to deeper layers and you start talking about how to advance the field, issues that matter. You start being provocative. You start talking about things that we did not talk about in other meetings or in other studies. So I think they nailed it really in this meeting. Congratulations to the organizers.
This is not an isolated liver problem. It's part of a multi-systemic disease. The relationship between the different organs is very complicated. So of course, we are focusing on the liver and we want to improve liver health, but we have to take into account that there are also other comorbidities.
How common is this underreported alcohol consumption in patients with NAFLD? The data supports something like 10% of patients with NAFLD. The stigma of high alcohol consumption is very high. People would not feel so safe to talk about their true alcohol consumption, but if we can verify that with a biomarker, we might be able to help the patient better if we have that information.
We probably don't have to improve cirrhosis, at least right away, meaning in terms of fibrosis, we can just stabilize it in the compensated state for a very long time, and that's an initial win as an initial first step versus people that they go on placebo or like not use useful drugs, they will progress to liver transplant and bad outcomes. So preventing outcomes and the decompensation could be a very attractive immediate short goal, especially for cirrhotic trials.
If I'm going to have a 20% effect in a population and the placebo is 5, that will do very, very differently on power calculation than if I'm going to have a 20% effect on a population I start at 25. Where all this arose originally was in response to the issue of, are we trying to get our placebo rates as low as possible? One answer was, well, yeah, because then you're managing the trial better. But the other answer was, you're not being as realistic to what you would like the patient to achieve.
In terms of trial design, we will improve. There's also a conference on the interorgan crosstalk that hopefully will help us to get our minds set about how we are dealing with that in clinical trials and then later on also in routine clinical practice.
This meeting talked about the role of liver and fatty liver and metabolic disease more holistically than I've ever seen before. And I've been doing everything for the last 3 or 4 years, and it has moved a lot, but this felt like a whole leap ahead. I'd like to believe that leap is going to continue.
Last week, leaders of industry and academia gathered in Dublin for the 2022 NAFLD Summit Conference. Join pricing and forecasting guru Roger Green and this week's guests, hepatology researchers and key opinion leaders, Professors Mazen Noureddin, Sven Francque, and Hannes Hagström, as they review highlights from the NAFLD Summit right now on Surfing the NASH Tsunami.
Today's episode of Surfing the NASH Tsunami has been sponsored by Resoundent, a Mayo Clinic company, and the developers of magnetic resonance elastography. MRE is widely available with over 2,000 locations worldwide and can be done as a low-cost, rapid exam in just 5 minutes. Together with PDFF, this quantitative exam is called an hepatogram, a powerful non-invasive alternative to liver biopsy in many cases. For more information, visit www.resoundant.com on the web.
So we are in Malahide, which is at the channel or the sea, I forget which, at Dublin. Gorgeous place. I'll talk more about that on the opening. We've just wrapped up the NAFLD Summit about 15 minutes ago, and we are here to discuss what's really been a fascinating conference. As Sven was saying a little bit ago, different subjects. I think there are a couple of good arguments. Mazen might even been in the middle of one or two of them. Louise did not make it to the event, and she's not here today. Joran did make it to the event, but he's having so much travel this month that he flew out before the podcast. So we have one podcast veteran. That would be Mazen Noureddin. Mazen, how are you doing today?
What's up, Roger? Welcome everyone from Dublin, Malahide.
Well said. And then we have 2 guests we've not had before, who I'm really excited about. On my left, we have Sven Francque. Hi, Sven. How are you today?
Hi, Roger. I'm fine and happy to be here. Thank you for the invitation.
And you sound good. In fact, you both sound pretty good. And then across from me, we have Hannes Hagström. Hannes, how are you today?
I'm very good. Thank you for the kind invitation to join this podcast.
My pleasure. And actually, Hannes is doing me a favor because we've never actually tried to record on my iPad before. But his computer would not let him download the Riverside app, so he's now working on my iPad. So with that, as I say, it's been a fantastic conference. A lot of really interesting stuff, a lot of great conversation. And I want to start by today's groundbreaker is going to be a little bit different. Usually we just ask one good thing that happened in the last week. But I'd like to ask instead one thing that you found particularly interesting or enjoyable about your time in Dublin. Ideally not about the conference, because we'll get to the conference later. But brave one, go first.
It was very little time because the conference was so intense and fantastic. But I enjoyed walking around the seaside, and we had a lovely dinner also with a lot of colleagues that we have not seen for such a long time. So that was really lovely.
Thanks, Sven. Mazen, you want to go next since you already jumped in?
It's along the same lines, actually. Meeting or seeing people after all this long time of not seeing everyone. It was very NASH intimate. So a lot of people from the NASH community, of course, there will be always people missing from the conference, but a lot of people from the NASH community to go out with them, have dinners, hang out, and chit-chat. So it was really lovely.
Along the lines from Sven, so I think I would have loved to stay a little bit longer and see more of Dublin, but we got to do a nice dinner in central Dublin at least by Thursday. So it was lovely to at least see a little bit of this great city.
So you can tell that these gents were on faculty and I wasn't, because I didn't get to go to a lovely dinner and chit-chat with all my friends. But although we got to do plenty of chit-chat in spare time, my moment is I did not stay at the hotel. I stayed one town down, which is called Portmarnock. It's a 4-kilometer walk along the coast road, and it is maybe the most beautiful walk I've ever taken in my life, certainly in the top 10. I walk down every day. I got my 10,000 steps in without doing any exercising. And it was just a wonderful way to start the day and to end the day. Today, I stopped and took about, I'm going to guess, 75 pictures along the way so I could lock the memory in my mind. And that was really a special thing that I didn't expect. Very, very nice. So with that, as I say, this conference was a 2-day conference broken up over 3 days, Thursday afternoon, all day Friday, and Saturday morning to 1 o'clock with tremendous content. And what I would like each of us to do is pick one presentation or one session that we thought was particularly interesting or compelling, take a few minutes to talk about it, and each of us will do that, and then we'll see what we've got time left to do. So brave one, go first. Who wants to start?
Okay, I can be a little un-Swedish and jump right in. So normally we Scandinavian people are a bit, back. So I'll contrast that and start. I think the session on overlooked topics in clinical trials was quite interesting. The discussion centered mostly actually around the topic of underreported alcohol consumption. And that's a long-standing elephant in the room, if I can say so, which has been talked about back and forth. But I think we now, in the past year or so, have really started to acknowledge that this is a problem. I guess that's the first step of also trying to handle the problem, acknowledging that it actually is a problem. So that was a lively debate, and I got some really interesting questions also afterwards.
What did you present that you'd like to share with the people who listen? Just kind of a thumbnail level.
So I guess the data I presented was a wrap-up of that topic. So how common is underreported alcohol consumption in patients with NAFLD, and what is the potential impact this might have on things like clinical trials? While it's difficult to know exactly what the impact is on clinical trials, I would say at least that the potential impact is rather high. So the data supports something like 10% of patients with NAFLD, if you take a specific biomarker concerning alcohol consumption, will actually have high levels of that biomarker, suggesting that they are underreporting alcohol consumption. And it's maybe not so surprising, because fortunately we talk also a lot about stigma. The stigma of high alcohol consumption is very high, so people do not feel so safe to talk about their true alcohol consumption. But if we can verify that with a biomarker, we might be able to help the patient better if we have that information. So I guess that's the bottom line. 10% roughly, at least in observational cross-sectional studies, seem to have a higher than we think alcohol consumption. If that's a problem for clinical trials, I'm not so sure, because at least my line of thinking would be that a person knows that they are maybe drinking a little bit too much might be very reluctant to actually enter a clinical trial. But if we don't measure it in a clinical trial, we don't know. And now there are rather simple and affordable biomarkers for alcohol consumption that we in Sweden use extensively in our clinical practice. So very much advocate for us to start adding such biomarkers at least once during the screening process in clinical trials to make sure we avoid that problem.
I went to a presentation on that subject in London at EASL, which will heretofore be known as the EASL Congress, which I think is a really smart piece of marketing on their part. Just use the name everybody is giving you anyway. But the person who did the presentation was academic, not necessarily a trials person in any sense, and was really delighted at how effective the method of testing hair was. without thinking about how long it took to get results back, or the fact that that would render participation in trials virtually undoable. So watching you talk about the same subject and not get to hair until like the third to the last slide and have a whole bunch of simpler, faster biomarkers made me feel a lot better about the subject. I don't know if it had any effect on anybody else. Other thoughts?
I think he did an outstanding presentation. I just want to comment on this session. It was a beautiful session. Both of you gave talks in that session, and I just want to praise the high scientific level in that session. I'm honored to be here with these two guys. It's my first time on the podcast with them. And for those that they are jumping the first time on NASH, let's say, I mean, our colleagues are very well known. Sven just had the New England Journal paper and many other papers. And Dr. Hagström, it's like we learned a lot from his publication that informed the field. So it was a fascinating session. I think the topics were smartly picked up. I think, Sven, you talked about the cardiovascular comorbidities. We talked about alcohol. I think in the future, there are others, but those were the most important. I think Isel picked them very nicely. But there are others, for instance, the kidney and how we don't enroll people with renal failure in clinical trials. People eventually with cardiovascular disease. We know in diabetes, they move to that now. We're excluding all those, as you said, rightfully so at this time, but eventually we have to deal with NASH and heart failure, for instance. It's just to give people an idea about the future where we're going to go eventually beyond the conventional method, hopefully beyond the biopsy, so we can enroll a large number of patient NITs, look at cardiovascular outcomes, and then we're going to explore the populations that now we exclude them, such as the cardiovascular disease, the renal failure, and all that. Saying that, I think it was put earlier in a nice way, the alcohol is a very complicated topic, needs to be continue to be studied and nailed down. There were discussions from that meeting about NAFLD and MAFLD, although it was brief, and a moderate alcohol consumption, so that will come into solution hopefully soon. But the point was brought up about terminology when talking about alcohol. For instance, when you throw alcohol in the mix, especially more than the amounts that we enrolled in clinical trials, you're changing the natural history, and that requires a whole new considerations. So I think that your talk covered a lot of important things in clinical trials, and I'm glad that was one of the assigned topics.
I agree with that. I'll come back to this later when I talk about what I found most interesting. But alcohol is a Hawthorne effect, because if somebody goes into the trial and actually drinks less while they're in the trial, one would suspect that after the trial ends, their alcohol consumption will go back to previous level. And as you'll hear when you get to my take on this meeting, Hawthorne effect, something I know a little bit about, was thrown around this morning and not necessarily used in the way it should be. But alcohol would be absolutely a Hawthorne effect. Sven, what would you like to talk about?
There were, of course, many interesting sessions. So making a choice is a difficult task that you ask. But one of the things that I was most interested in was a session on Friday afternoon about how treating comorbidities also can have an impact on the treatment of NASH. And we were fortunate to have some non-hepatology colleagues in the meeting, endocrinologists, obesity physicians, giving their point of view. And some of them have also long-standing expertise in NAFLD, so they are really not new to the field. And then it's interesting to see how their approach is a little bit different sometimes from our poor liver-centered view. And they have newer guidelines, and NAFLD is coming into it. And also the concept that with some of the drugs they use, they are also doing something beneficial for NAFLD, like pioglitazone has been mentioned many times throughout this conference. Semaglutide, obviously, also bariatric surgery. So all treatments that have tremendous impact on comorbidities that are linked to NAFLD. But for some of these, we also have data, phase 2 data, that it's beneficial for NAFLD too. And they start really to incorporate that in their therapeutic management of patients. And we discussed also a little bit, and one of the colleagues has put forward a question. You're doing that, but you do not have phase 3 data. Then you get again to the multidisciplinary approach where they say, okay, but we are not using them off-label. We are using them for our patients with obesity or diabetes that have NAFLD. So it's within the registered indications, but it's tailored and it takes into account that there is also a liver problem. And I found that multidisciplinary approach and that take on the disease by non-hepatologists a very interesting evolution.
So, one of the things that we're doing right now is we're doing a special series on patients with type 2 diabetes and obesity and how should you think about treating them. So a lot of those topics have actually been coming up in that podcast as well. Here, though, I think just a lot more of it. And I agree with you that getting people in from other specialties has helped tremendously. I also would like to comment on the talk you gave, the cardiovascular talk that Mazen mentioned, which I found eye-opening. I learned a bunch. because we all know that that's an issue, but getting it into context and getting beneath the first two sentences of the story, I think, are really important. So it was helpful to be able to watch you lead us through that. I thought that worked out really well.
Thanks for your positive comments. But indeed, I think this is not an isolated liver problem. It's part of a multisystemic disease. It's more a syndrome, if you want. And the relationship between the different organs is very complicated. So, of course, we are focusing on the liver and we want to improve liver health. But we have to take into account that there are also other comorbidities that are quite intimately linked to NAFLD. And we should incorporate that in our clinical trials and also in our routine clinical practice, not just from a safety perspective, because that's mostly the point where we are looking at now, but also from an efficacy standpoint, because many of the things that we are doing can be beneficial for the liver and for the cardiovascular system. And of course, we do not have trials with thousands and thousands of patients, although in the phase 3 trials, we are approaching those figures. And we still do not have trials with 5, 6, 7 years follow-up. That's probably what we need for cardiovascular events. But there are ways to already now incorporate some aspects in our clinical trials and at least get some preliminary data and a first idea how we can better integrate that aspect of the disease into our clinical trials to increase our knowledge and to have a more tailored approach in the end for our patients.
So, question to everybody. Compared to other meetings, it felt to me like this meeting did a better job of thinking integratively in the way that you described, Sven, than, a lot of the other meetings. Everything feels like it's kind of stovepiped. You get a session about a fairly narrow element. You have lots of different sessions. NASH-TAG is a little bit different, and this is different.
I was going to say that my colleagues are at EASL, arrange meetings and all this. Same thing for AASLD. When we try to plan things for AASLD, sometimes you have to be very specific, given the short time in general for the meeting and the topics covered and the audience as well. Because in big meetings like this, you have to consider the clinical hepatologist all the way to basic science researcher. So you have to cover so many things and so many aspects. In meetings like NASH-TAG and this one, you get to deeper layers and you start talking about how to advance the field, issues that matter. You start being provocative. You start talking about things that we did not talk about in other meetings or in other studies. So I think they nailed it really in this meeting. Congratulations to the organizers, and it was a real privilege to be here. Can I go back to the comorbidities? One of the things also that we eventually need to talk about and we need more data in is the type 2 diabetes and the effect of glycemic control on drugs and their effect on clinical trials. As you know, right now in all clinical trials, and I think that came from the Liver Forum or somewhere, that the A1C 9.5 and above is the exclusion criteria for clinical trials. And there is some data now coming from Minal Abdelmalik's group that the type 2 diabetes might affect the placebo group, the maybe severity of the disease, although you will think it's logical, but we need more data on the effect of type 2 diabetes in NASH. And is A1C of 12 and 13 worse for the histology as well as response to therapy and all that stuff? And this is again unexplored group that we just want to find an effective drug for now, and we're trying to isolate any big outliers that they can affect the disease history, CKD, A1C of 14, and all that stuff. So that's back to comorbidities. But as you to go back to your comment, the integration was outstanding.
Yeah, I very much agree. I think these smaller meetings with just a few hundred people are more beneficial in terms of communicating with each other and acknowledging some things that are tricky to discuss in the bigger meetings. So I really liked we also had a session on why some clinical trials have failed, and just incorporating that session is just to me a sign that the field has matured a little bit, that we are trying to learn from our past lessons and really trying to come up with the best way how to design these trials. And one thing I think we, Manal Abdelmalek, talked a little bit more is that maybe we need to acknowledge that stability of fibrosis, for instance, is perhaps something we should look into more in detail as an outcome. What do you think about that?
Yeah, I mean, I can comment on that as well. I think it depends on the disease stage and where you're at. And I heard the first person talking about this comment was Scott Friedman the first time. I remember we're all thinking about different aspects, but one of the things, it was probably on this podcast on one of the meetings, that we probably don't have to improve cirrhosis, at least right away, meaning in terms of fibrosis. We can just stabilize it in the compensated state for a very long time. And that's an initial win as an initial first step versus people that they go on placebo or like not use a useful drugs, they will progress to liver transplant and bad outcomes. So preventing outcomes and the decompensation could be a very attractive immediate short goal, especially for cirrhotic trials. And I also want to comment on this session that they explored the failures in the drugs, which I'm going to borrow your terminology. You called it the autopsy session. Roger called it that earlier. I think it was very informative, and it just talked about, I think when Stephen Harrison started talking about it, talked about general things, and then he went to selonsertib. So he did a nice summary of the possible causes of failing clinical trials. And I would recommend people to go there on demand and look at the slides and the breakdown. And then it kept getting better and better. I mean, they were all 10 over 10, but Scott went into the animal models and talked about it very nicely. And who was this? It's Elizabeth. So she did also outstanding job talking about alenifibrinols. So it was an outstanding session as well, which I'm going to go back to that session and ask a question when I start talking about my session. The more I'm sitting here, we're opening up, I'm just recalling the rich meeting. So we don't forget at the end, I think we should probably talk about NIT, which is very attractive subject to this podcast, as well as therapeutics. So I gave a talk in the NIT sessions, but I'm going to jump to therapeutics to allow more time for discussion. I think that was a great session. It was started by Vlad on the phase 1 and 2. And then Manal talked about phase 3, and Sunil talked about the cirrhotic trials. So a million things crossed my mind, but I just want to emphasize this is the closest meeting to the recent 2 announcements. The Akero data, which was presented at this meeting, it was very impressive. As you guys know, this is histological data from the Harmony study. And I don't know if it was announced already on the episodes or there's episode coming, but in the context of this meeting, NASH resolution was achieved, I will call 75% without fibrosis worsening. The remarkable results, actually, that was 41% improvement in fibrosis without NASH worsening, and another 41% with both fibrosis improvement and NASH worsening. So that was highlighted in that session very nicely. And the other one, the Altimmune dual agonist, GLP-1 and glucagon, and they discussed there was no biopsy, it was phase 1B, but the amount of the weight loss was significant, and the amount of the defattening of the liver or the fat loss within a short time, 12 weeks, it was really incredible. So there was a lot of optimism from this meeting. I mean, Arun Sanyapi, and he's very careful with his words and precise, and he shared the optimism that happened, especially recently with 2 good drugs. This meeting highlighted that very well. I'm going to throw something out there, could be a little bit provocative and maybe open a little bit discussion with others. Manal actually presented very nicely the phase 3 data, and I stumbled a little bit and could have died. And I was wondering, based on the previous session of why trials can fail, if phase 3 is the right next step for them or not. She was talking about them going into phase 3, if I remember correctly, right? So I was a little bit questioning, is such an attractive mechanism, GLP-1 and glucagon agonist, enough to justify? Because I mean, the drug, as you said, it's a multi-system disease, and it's a drug that hitting diabetes, obesity, and all this, and has been really attractive. So the question is, I guess, what everyone thinks about that part of the presentation in particular.
I don't know, Mazen, if I capture the question right, because what is going into phase 3 is already with scotellotide has phase 2 data. So that's not really the issue, I think. One of the issues, of course, is the endpoints. It's a regulatory framework we need to work in. And that framework has been shaped by some hepatologists quite a while ago, and is still the framework we need to work with. And if we talk about the many failures, one of the reasons is, of course, that we have very high barrier crude endpoints, missing a lot of granularity. And some of the drugs that have been tested do have some effects, but the effect size is too small to really hit those crude endpoints. What we are seeing now with the encouraging drugs that are coming up is that the effect size is way bigger, mainly because they are really targeting the root cause of the disease, being the metabolic drivers of the disease. They're not just hitting that. It's quite complicated mode of action, but they have a strong impact on that. And probably that's one of the main reasons why that translates into higher percentages of improvement both in NASH and fibrosis that really makes them hit those crude endpoints. So it's not just about the definition of the endpoints, that's part of the issue and the lack of granularity there, but it's also the fact that these drugs are more powerful to impact on the root cause of the disease and to translate into larger effect sizes that in those very heterogeneous groups of patients still result in significant results.
Mazen, are you talking about a development strategy as a marketing or commercialization strategy, or are you talking about it as a medical learning strategy, or both?
I'm talking about drug approval and reaching endpoints in phase 3. So I guess you answered me what I was looking for, that it's probably justifiable to jump on to phase 3 if the drug is hitting the root cause and has the drug class has shown more efficacy across trials. Nevertheless, it seems like the GLP-1 glucagon agonists are not created equally when they address the body as total, and that has been shown in the amount of weight loss across these drugs in general. So
I think what we also learned, and I think Stephen Harrison mentioned it, even if we have quite some good preliminary results, there should be a decent phase 2 before going to phase 3. That is also an important lesson learned anyhow, even if results seem to be very promising. Yeah.
I thought that was right. The idea that drugs were failing because the phase 2 was inadequate to teach what you had to learn to get to phase 3 right was, I think, an important point. One thing that Elisabetta did not talk about that I hoped somebody might was, if you don't hit your primary endpoints in phase 2B, but you can torture your data so it looks like you've hit something of value, should you do that and go on to phase 3? Or should you say, we're just not going to make this work? Right? Because I think that was part of the GenFit story, and that was part of the OCA story also. Phase 2Bs that did not hit their primary endpoints that needed to be reinterpreted. GenFit, the drug, as we know, crashed. And OCA, we're still waiting. I think one of the reasons that happened, though, is that the profession wanted the drug so badly, and we knew so much less than we do now. We saw 5 phase 3 candidates today that all look pretty good or better. So, Mazen, first to let you know, next week's episode is going to be about Akero and the other new studies.
I agree with you. To answer your question directly, if it's negative 2B, would I go to 3? I want to start with the logical answer is no. I mean, yet we all know that maybe NASH resolution is a higher bar now, although a lot of drugs started hitting it. But maybe there's a less effective drug that eventually can work out. I would say at the current time, if histology is the outcome, we all have to deal with inter and intra-observer variability, Hawthorne effects, placebo effects, you name it. So if your phase 2B on histology is negative and the regulator is still requiring the same endpoints, the same way, the same everything, I'll answer from physician standpoint. I'll probably be less likely to put my patient in that phase 3. I want my patient at least to have some benefit. I mean, I don't want it to be very slim in phase 2 or negative and put them on a phase 3. So that's my immediate answer for that. Not thinking about what pharma does, not thinking about the financial consideration and all that.
So you have to remember, though, aldafermin, MGM kills the drug, and the stock market rewards the stock price, because we're now at a point where we've seen enough things blow up in 2B that investors are skittish about putting any more money behind a small company with a 2B failure. And aldafermin wasn't really a failure. It was just one bad data point at one dose.
We talked about aldafermin before, and Arun mentioned it during the meeting, and I totally agree with him. I think the drug worked with the secondary endpoint, which is one of the primary endpoints that the FDA requires in phase 3. And I do support their cirrhotic trial because technically they hit one of the endpoints that has been established as primary efficacy endpoint. So just wanted to throw that out there.
We should also not forget that the landscape has drastically changed. So if you look at the phase 2 GenFit data, you see some effect on steatohepatitis. It's not just NASH resolution, but if you look at the individual components, you see a clear effect on the steatohepatitis. That does not translate it in the overall population in fibrosis regression, but those that had an improvement in steatohepatitis also had some improvement in fibrosis. So at that point of time, given the competitive landscape at that moment, I think it was quite justified to explore that drug in phase 3. And phase 3 confirmed that there was some effect on steatohepatitis, but not strong enough to translate into an effect on fibrosis. So I think that was perfectly justifiable. And that's what we have seen with other drugs. Now we are in an era where, especially with the metabolically active drugs, you have larger effect size, more pronounced effects. So if in a phase 2 you only have marginal effects, you're not likely to beat the competition. So then you can say, okay, that doesn't make sense to go to phase 3. But that's a different landscape than when decisions have been made on elafibranor and other compounds several years ago.
I think that's very well stated. The time, what was available then, the clinical trials, the outcomes. I mean, at one point we were at 2-point NAS improvement. That is a past. So it's evolving field, and I always say it's easy to criticize after the fact and when things fail, but you really have to put yourself in these people's shoes when, let's say, they did it December 2018. What was the landscape? What was the best knowledge they did? And what did they come up with? Was it their best judgment and best knowledge at that time? So I totally agree with Sven on this.
Remember that in the early areas of Hep C, we were quite happy with a few percentages of SVR.
I got to work on all that stuff. A lot of the drugs that didn't do very well or did okay. The earlier Hep C drugs we did pricing and forecasting for, and I did a lot of that for Ella, also for GenFit. I think the point obtains. The other difference, though, frankly, is that I think at that point in time, investors wanted the drug to succeed badly enough that you could get the money you needed to do the phase 3 trial. So I think the investors are a little skittish about trials that have failed, or the trials that have failed have made investors skittish even about good drugs.
Again, we discussed it. At that time also, SEMA was around, and the effects was much better on NASH resolution. And it's a drug that addressed the entire body with weight loss and prediabetes and all this. So it's probably the right decision. I'm not sure. But yeah, as Sven said, there's like a lot of other cofactors in the field and the science and the market, as you're saying, Roger, that there are a lot of considerations that the sponsors taken.
I totally agree with that. I want to go to one of the issues that underlied a lot of the meeting that I'm going to come into in kind of a funny way. The issue is, what are we trying to do here globally? And the funny way I'm going to come into it is through the discussion this morning about Hawthorne Effect, because what was described this morning as a Hawthorne Effect isn't. And I'm not just being picky, it actually matters. A Hawthorne Effect is a research artifact. In the original study, you have a wall that's white, you paint it green, productivity goes up. Productivity drops, you paint it white, productivity goes up again. So whereas they originally thought it was the color that you paint the wall, it turns out it was just the fact that you paint the wall. And that's a research artifact, and those are the things that you want to avoid. Here, what we were calling a Hawthorne Effect is that we educate patients in the placebo group, and as a result, they perform better, which creates a better placebo response and therefore a higher standard for the drug. But the question I was asking myself, and because I'm not a researcher, I wasn't going to go behind Mike for this, is if what we're here to do is help patients, then at the end of the day, in the reality of life, we hope that we will get better at educating patients on how to take care of themselves at the same time the drugs come to market. So what we were calling a Hawthorne Effect is in fact the environment that we'd like to create. And then it's not a research artifact, then it's an effort to simulate, if you will, to manifest the future you want to have. And I think really a good thing. Now, it makes it harder to get the drug approved, but it makes it a lot more realistic in terms of thinking about where might we go. So it's an interesting question.
Let me just play the devil advocate on this. So you agree that the Hawthorne Effect is when individuals modify their behavior because of the trial?
No, I would define the Hawthorne Effect as a research artifact if they modify their behavior because when they go into trial, they learn how to take better care of themselves, and therefore they do that. And many of them may continue to do that after the trial is over. That's not a Hawthorne Effect. That's a behavior change. Hawthorne Effect is a research artifact. So, for example, when Hannes was talking about alcohol before, and I said that's the Hawthorne Effect, people are going to start drinking again as soon as the trial's over. I get that part. Here, I don't know, though. And by the way, even if they go back to the behavior they had before after the trial, in 5 years, when we've got $10 billion in sales and a lot of drugs, and therefore a lot of patient education, we're going to be trying to educate patients to the level that they're at while they're in the trial, not the one they were at before or after. So that's why I didn't think of it as a Hawthorne Effect.
I mean, you can look at it different ways. But my counter argument that if a patient go on a trial and they modify their effect or they start exercising and losing weight, are they going to continue that? The answer, what we know from the literature, is most likely not. I'm not saying we shouldn't compare to, we should start with, just to be clear to everyone, weight loss and exercise is essential. People need to change that. People need to eat better. People need to walk 10,000 square foot on a bridge, and even there's no bridge, nice views, they should do that. But in a clinical trial, the question is, do they go change their behavioral, affect the drug, and then get out of the trial and back to where they're at and the drug is affected? The other point is, we know, for instance, the Largoma study in gastro, now it's like they're very highly cited, that it's very hard to achieve weight loss, especially for 10%, and most people reverse after. I mean, like they go back to what there was. So I think it's a complicated concept on the modification and within NASH clinical trials.
Yeah, I fully agree. And I think also we can learn something from other fields. I mean, the obesity field and diabetes field have looked extensively at weight change and what happens. And there's actually a rather nice study where they examined people that was in the first season of this TV show, Biggest Loser. So they dropped, I don't know how many kilos. And then 7 years later, everybody goes up. So even if you have dropped 150 kilos, there's something that keeps you to regain that weight. And I think that has sort of reflects very much how our patients with NAFLD and NASH will do. So in the long term, of course, lifestyle changes are essential and we should do what we can to help them. But I do think they need something to help them to maintain those effects. And there's where a drug comes in, because I don't think the healthcare system will be able to manually support people with repeated follow-up times, etc., in this huge patient population. There was actually one abstract at the conference where they compared the efficacy of a very simple support from a dietitian in London. I think it was from the Francque group, and just saying that, patients that got supported by a dietitian were much more likely to have a regression of their FibroScan results, giving some indication that they might do better in the long term. But, having a dietitian with continuous support for all of our patients, I'm not sure if it's going to be feasible. But
So I'm going to play the role of Louise for a minute, because I know how she would answer this. And Louise, if when you're get around to listening to this, I got it wrong, you can tell me what the prize is. One of the reasons she's so fond of FibroScan is that you actually get to give a patient a result and show them a picture when you see them. And her comment is, when you do that, it's surprising how many people were motivated. Somebody in the last diabetes episode said almost exactly the same thing, and that was not Louise, because she wasn't in that episode. So if we managed our patients a little differently, it wouldn't solve the whole problem, Hannes, not even half of it. But we could do a lot better than we're doing right now. So I think the truth is probably somewhere at the intersection, half of one, half of the other.
You're for sure right that the patients are interested in those kind of results and that it can be a motivator. Coming back to the issue of the clinical trials, I don't think that it's that important. I explain myself a little bit better. The placebo effect is not going to kill the results of a trial if you take it into account properly. It will happen anyhow. And if the groups are well calculated and your power is okay, what happens in the placebo group should also happen in the treatment arms. So in the end, you need to take that into account in your power calculation and make sure that your trials are sufficiently powered. But that will not kill the drug if that is properly done. With the Liver Forum, we have struggled a lot with how to have lifestyle modification. How should we do that in a clinical trial for NASH? And it was a whole journey to come to a consensus, because learning, as Hannah said, from the obesity field or the diabetes field, you could think of doing a lead-in or have something standardized implicated in the trial. Because ideally, you start a clinical NASH trial with patients that have gone through all that lifestyle modification, education upfront. Of course, that's not the clinical reality, but that should have been the case in the ideal world. So we have come up with recommendations that have also been shown during the meeting. And I think if you have a properly designed trial, sufficiently powered, that effect is, of course, important and explains the placebo effect, but that's not really a problem in terms of analyzing the results and deciding on whether your drug is doing more than placebo or not.
On that level, I completely agree with you. I think part of the issue there was, if I'm going to have a 20% effect in a population and the placebo is 5, that will do very, very differently on power calculation than if I'm going to have a 20% effect on a population I start at 25. Where all this arose originally was in response to the issue of, are we trying to get our placebo rates as low as possible? And, one answer was, well, yeah, because then you're managing the trial better. But the other answer was, you're not being as realistic to what you would like the patient to achieve.
I mean, the way I look at it, it's prepare for the worst and hope for the best. That's what they say, right? So that now we have a very clear data, although it's a little bit fluctuating, but we have multiple meta-analyses that showing what's the placebo response rate. So rather than going into a trial and try to design it based on a lower placebo rate, you can do 33% if you like what happened in the Summit trial, but I would not recommend that. I recommend what has been shown, and I wouldn't throw it out there as 20%. Our first meta-analysis showed 23%, and the second meta-analysis that Francque discussed in details, and by the way, I'll go ask the author on that publication, but let me give the right credit to the right people, which is the Singapore group by Mark Mathaya and Cheng Han, that they did this nice meta-analysis. That's where it came from. It's 18% for regression for fibrosis and 22% for regression, actually. So I think that range is reasonable. And then, of course, after that, you have to leave it to Mother Nature nature and see what it comes. But now there are some semi-consistency in what you can put in a power calculation.
Excellent point. So while we're talking about debates, I think we'd be remiss if we didn't talk about that whole debate around NITs the Thursday afternoon, where you were on the podium Mazen trying to light Quentin up, among other things.
But he was very balanced and took it well. I was trying to put Kaz on fire between Vlad and Quentin, I know. So, I mean, I can start with the first presentation, which I gave about the serum biomarkers. At the end of the day, I can give you the summary. I think eventually we're going to move between combination and serum biomarkers. And it has been said multiple times in this conference that one NIT by itself, it's not going to be the answer. We think for now, it's probably going to be a combo, as we say, and we said that on this podcast multiple times, combination of non-invasive testing to risk stratify, find at-risk NASH patients, and then mention response to treatment. And in terms of the serum biomarker, I just don't want to go by one, but I will summarize it in terms of the context of use. I will say to stage and find at-risk NASH were at a very good place. Outcomes, the first one is probably excellent. Outcomes, I think we have good data. We are totally conscious to what the regulators want. They want larger cohorts, prospective, and the example that was given, like the New England Journal paper for outcomes. And I think we're in the process of doing that. And lastly, I think the best paper was done on treatment response was from the Regenerate data by first authors, Mar Ranella. And it shows you that we need more work on the response to therapy. So for instance, they showed individual markers, ALT for instance, correlate with histology worsening and improvement, but by itself it was not good enough. And I'm surprised they didn't combine the NITs in that paper and looked at the combination and their correlation with improvement in histology. And then if you want to comment on serum or someone to comment on the imaging biomarkers, please feel free. I'll stop with this first.
So just a general non-invasive comment is that we touch upon sometimes, but not always, is where do we want to use the said biomarker? For instance, I mean, we sometimes forget that this is a population disease with a huge prevalence, and then the first line biomarker needs to be in primary care, and then it needs to be extremely cheap and simple to use. So I don't think we can have a very complicated biomarker built on bioinformatical approaches and things like that that is very complicated to set up, that we want to use in a primary care setting, because that is where the patients are found. So there we need something very, very cheap and simple. So sometimes we forget that.
No, I totally agree with that. I personally, I'll tell you, that's my intake on that. I'm 100% with that. We need to increase awareness and education, and the biomarkers in the primary care or people that they are not involved in the liver should be simple, cheap, and cost-effective. Yet, I don't think necessarily eventually in hepatology clinics, especially when we have drugs, I don't think we will use the same set of biomarkers. And I'm actually going to quote one of your papers, the FIB4. I think the FIB4 is, and I told you I'm a fan of that paper. The FIB4, I think it's an outstanding step by both AGA and EASL, and it's probably going to be AASLD. I'm not sure what the algorithm they're going to come up. And it's going to move us from missing a lot of patients in primary care to the right step, identifying them and sending those. And it's been used in hepatology clinic, but eventually the hepatologists, after they get the patient identified with a good test and cheap, they have to do a little bit deeper dig and find at risk and F2 and all that. And on one of the summary slides, I said new biomarkers are still welcomed, although some people say it's competitive, too many and all this. And one of the papers I use is yours that, correct me if I'm wrong, when you showed that people in the low or indeterminate zone, almost half of them had clinical outcomes at the end.
So what we found in that particular paper was that in a general population of hundreds of thousands of people, 140 I think it was, then of those that do develop liver-related outcomes, that is decompensation or progression to cirrhosis or liver cancer, almost half will actually be in the low group if you only measure FIB4 one time. But if you repeat your FIB4 sampling, you can increase that proportion. But I certainly agree that this is the first line biomarker, and then you can of course have more advanced things going on in secondary tertiary care. What I would also like to try to do is that, FIB4, it has a few years back now. It's been designed to pick up F3, F4 in patients with HIV, HCV co-infection. It seems to work very, very nice also in other liver diseases, but it is a diagnostic marker. It should be possible to recalibrate this given the current situation we are in. So we have recalibrated MELD, things like that. I think it's would be very interesting for a recalibration of the FIB4 to be used in a general population, and also recalibrate maybe for use as a prognostic biomarker for prognosis.
I just have a quick comment on that. I smell papers coming. That's my comment.
A word of caution, though. I think, of course, the NITs are very important for the future, but we're talking a lot about the limitations of the liver biopsy. We're talking very little about the limitations of those non-invasive tests. They all have their limitations. Intraperson variability, interlab differences, all things that we need to take into account. And also for liver stiffness, if you measure it today or you measure it in 2 weeks, it can be quite different. So we really need a combination of markers and take into account their intrinsic variability. And it's only by combining, whether it's histology or serum markers, imaging markers, that is something, especially if we want to assess evolution over time and treatment efficacy, it will need to come from a well-thought combination of parameters so that you can account for that intrinsic variability and the limitations that all these different parameters have, whether it's histology or something else.
I think that makes excellent sense, Sven. And if we were in the States, this conversation would have had a lot more FibroScan and MRE in it, because the economics of healthcare in the States just says there are a lot more FibroScans and MREs around. And in fact, I was surprised there wasn't more VCTE in this meeting. And then I said to myself, I know why. There just aren't as many devices. I think you're right. I mean, we're balancing cost and all kinds of other issues. Mazen, go ahead if you have something you want to.
Before we move to the NIT, I just want to repeat what the regulators are looking for, and ask the help of my colleagues if I understood it correctly. Some of you, I was in a different country. I was in Argentina with the Paris-NASH, but there were multiple discussions in Paris-NASH as well as here. What the regulators want to have NIT as a primary efficacy endpoint, for instance, in registry study. And the conclusion I'm getting, and I'm really trying to make sure I got it correctly. The conclusion is that we are not ready yet. We need more data. Some examples were given, which was the New England Journal paper about outcomes and prospective large cohort studies, which was initially discussed in different episode. You can go back to that one, is the NAIL NITs, a large study with NITs and outcomes. But that was my understanding from the regulators. I don't know if anyone got a different kind of sense from them or has a better idea that how we can do that retrospectively to convince them to replace a liver biopsy in phase 3 studies.
So that's something I think about quite commonly. We were one of the groups showing that if you do a retrospective study showing that fibrosis is a key marker of prognosis, which is at least what I think partly convinced FDA and EMA to use that as a surrogate outcome. So why can't we then also do large-scale retrospective studies of, for instance, now FibroScan or non-invasives to show the same thing? Actually, there are studies showing that the prognostic information you get from this FibroScan is comparative to that you get from a liver biopsy. So some information was presented here where showing that actually if you show that a regression of fibrosis might be associated with lower risk of outcomes, but I think the same thing can rather soon be shown for VCTE measurements. So now it's been around for quite a few years now, so we should be able to do those kind of studies.
I agree. The question is, I totally agree 100%. But it didn't feel to me that the FDA is ready to take that. If you guys agree,
I agree, but I just don't understand why.
I'm with you.
If I understand, they are open to consider it. I think that Elmer Schnabel even used the word sympathy, but that they are not convinced by the current data that we have. So I think we need to come up with much more data, especially the correlation between treatment response and the evolution in those NITs and what the magnitude needs to be to translate into an efficacy endpoint. So
that's true. And to give them a credit, I think they really want to go the direction we all want to, which is NIT, replacing liver biopsy, even in clinical trials. But at the end of the day, they have responsibility and golden standards for agencies to go by. I think they're asking us to come forward with more and more data and go to them and try to replace it. And we're in the process of starting these conversations and continuing them and hopefully move that forward.
Sometimes it feels a little bit to me like watching an 8-year-old try to go off a diving board, and they get to the end and they just stand there and they stand there and they stand there and they stand there and they stand there, and you don't know what's going to make them jump until ultimately their father or mother comes along and pushes them. I don't know where that push is going to come from, but it is kind of how it feels to me. So at any rate, we're at the bottom of the hour. So before we go to wrap up, is there anything else in that meeting that anybody wants to make sure that we comment on because our audience should hear it?
It's a totally off-topic thing, but I think it was very impressive to see that there were actually some Ukrainian scientists coming here to present their data, which is very remarkable in the current situation. So I thought that was very nice to see.
Just a minor point about the liver biopsy, because we discussed that a lot, but still I was impressed by the new techniques that can help us improve the information we get from the biopsy. And although, of course, the biopsy will not be there for routine clinical practice, but it's still a very valuable tool, a lot of information also to help us understand the disease. So that was an important message, I think, also from this meeting.
My final word, just want to congratulate Manolis, Emilia, and Francque for organizing this outstanding meeting. And for EASL in general, they have been changing the field significantly with JHAP and such meetings. So let's keep it going and change the field.
Yeah, they've done really well. I'll tell you what my scariest moment of the meeting was when Vlad suggested that the U.S. hepatologists, no, actually, he said about Tina and about Valerie, that they come over to the States and they could train all the hepatologists who aren't doing liver biopsies to do liver biopsies, and then we could do enough liver biopsies to treat all the patients. And I was like, oh God, no. No.
I think we have good people also in the U.S. I tell everyone I'm an American citizen married to a European, so by heart I'm both. So.
In closing, when we come back here next year, or back to this meeting next year, I don't know if it's going to be in Dublin next year. When we come back to this meeting next year, what will have changed? What's the one most important thing, in fact, that will have changed over the next year? Brave one, go first.
You're going to have the resmetirom and obeticholic acid decisions. Let's see what else is going to finish. I think those the major ones, and many phase 2s they will read out. I think it will hopefully look more rosy by next year. And from my own bias, we'll start the NIT outcome study to replace biopsy in phase 3 studies. I mean, those are my major highlights.
Okay, go ahead, Hannes, Sven, whoever wants to go next.
I can echo Mazen. I think those two studies will be very, very interesting to see final results from, and hopefully that will trigger the field to even more activities. So looking forward to 1 year from now.
Meanwhile, in terms of trial design, we will improve. There's also a conference on the interorgan crosstalk that hopefully will help us to get our minds set about how we are dealing with that in clinical trials and then later on also in routine clinical practice. So a lot to come.
To me, the conceptual difference follows from what you just said, Sven, which is that this meeting talked about the role of liver and fatty liver in metabolic disease more holistically than I've ever seen before. And I've been doing everything for the last 3 or 4 years, and it has moved a lot, but this felt like a whole leap ahead. I'd like to believe that leap is going to continue, and I think between that leap continuing and if resmetirom and OCA do well, the money that will come into the space, we'll just be rolling next year. Anybody have anything else they want to add before we say goodbye?
No, I can just confirm that the content of this meeting was excellent, and I think we should really congratulate the 3 organizers on a very smart design of the program. That has been really key, I think, to make this meeting a success.
Smart design is the right word, actually.
Smart design is the right word, and since you can't see video if you're in the audience, then you don't know that Hannes gave it the thumbs up also. So with that, let's sign off. I'll come back and do business report in a little bit. Sven, Hannes, welcome to the surfing community, and see you all later. Thanks.
Today's episode of Surfing the Nash Tsunami has been sponsored by Resoundent, a Mayo Clinic company, and the developers of magnetic resonance elastography. MRE is widely available with over 2,000 locations worldwide and can be done as a low-cost, rapid exam in just 5 minutes. Together with PDFF, this quantitative exam is called an hepatogram, a powerful non-invasive alternative to liver biopsy in many cases. For more information, visit www.resoundant.com on the web.
And now for the Season 3, Episode 46 Business Report.
Slava Ukraini, Heroyam Slava, glory to Ukraine, glory to heroes. Ukraine continues to make progress in the war, both on the battlefield and in world insight and resolve and opinion. Let's hope that resolve holds through the winter.
As you just heard, Dublin was a fantastic meeting.
As you can hear from this episode, the NAFLD Summit included a tremendous amount of high-level conversation, some politely contentious debate, and a great spirit among attendees. Note to self, next year I need to do the Paris Nash NAFLD Summit double.
Like last week, downloads for Nash Tsunami are flat but strong. Rising tide is rising even faster.
Nothing much new on either front here. Downloads this week are roughly where they were last week and would probably have been higher for NASH Tsunami, but flight schedules and other logistics made us unable to release the conversations until Monday. As a result, downloads have stayed slightly below 2K a week, but still way above where they were at this time last year. The Rising Tide pilot series more than doubled its gate entries in a week. Keep your eyes open for information on the 4th episode in the series coming probably in a week and a half.
This week's Vault episode is about weight loss and cirrhosis, a theme that came up in Dublin.
This week, we're replaying Conversation 61.3 from Season 2, part of our coverage of the Splendor study of bariatric surgery and cirrhosis. This conversation addressed two issues: whether cirrhosis can ever truly and completely be regressed, and what the impact of greater weight loss with GLP-1 GIP dual agonists or GLP-1 glucagon dual agonists or even a triple agonist with all three effects might be on NASH. The answers are compelling. The data that's emerging might even be better than what we were talking about in that episode. So with that, I'm off. Thanks to the crew, Jake, Magic Mike, Eric, Steve for working through a somewhat difficult schedule with me on the road, and to Mike for taking an episode recorded live in a sound space that scared the stuffing out of me into the high-quality episode you just heard. And as always, most importantly, thanks to all of you for making this such a worthwhile labor to pursue. We will be back next week probably talking about some of the exciting recent drug studies. Until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.